Good afternoon, everybody, and welcome to the webinar, Talking Sex with Teens, Community Health Centers Act for Change, which really translates to a primary care response to adolescent sexual health risks. Before we get started, I just want to say thank you to the Centers for Disease Control and Prevention, the Division of STD Prevention, for their support of this project. We have three presenters today. I am Dr. Jennifer Salerno, and I'm the founder and CEO of Possibilities for Change. We also have Ashley Barrington, who's the Director of Public Health Integration at the National Association of Community Health Centers, and Stephanie Rose, who's the Project Director at the Health Center Network of New York. Before we get started, just a little bit of housekeeping. What we'd like you to do is view the presentation in full screen mode. There's some slides where we provide some information on results and things like that that might look small if you're not viewing on presentation in full screen mode. And you can ask questions by using the question box you see in your GoToWebinar panel. It says questions. You can type your question into the panel as we go along, but we will be answering questions at the end. So since you're joining us for the webinar, we assume you're interested in adolescent sexual health, that you might be working to improve services within your organization around providing sexual health to this age group. So we wanted to start the webinar by giving some background to kind of set the stage for our project discussion. So as we know, risky sexual behaviors start at earlier ages, and the 15 to 19-year-old group is at highest risk for STI and unplanned pregnancies. Some of the most recent, which was 2015, Youth Risk Behavior Survey data that comes out of the CDC, shows some of those sexual behaviors you see in this data table as contributing most to STI and unplanned pregnancy. So what we did was kind of pulled out those behaviors that contribute most or been shown to contribute most, and wanted to show you what the high school youth were responding related to these behaviors. So you can see ever having sex, and the last time they had sex was just over 40% for high school age youth, which was 9th to 12th grade. If you look at just the 12th graders, you'll see much higher numbers in most of these behaviors. So we know as teens get older, their risk behaviors also increase. In addition, there are some subpopulations that are at higher risk for STIs and unplanned pregnancies, and those subpopulations are sexual minority youth, African American and Hispanic youth, and youth living in poverty. So if you're serving youth within these populations, they may be at higher risk as well. In addition to what you typically think about when it comes to risky sexual behaviors and sexual health, like condom use and number of partners, there's research that suggests these risk factors also contribute to unsafe sexual decision-making. So those include substance use prior to sex, feelings of depression and low self-esteem. We don't always think about that in relation to choices around being safer when teens are having sex, if youth are homeless, if they're not doing well academically or don't have future goals, they're engaging in sexting, which is new over the last couple of years, and then if they've had a history of abuse or in a dating violent situation or coercive partner, they're at higher risk for unsafe sexual decision-making. Current practice around sexual health care of adolescents, and what I did was pulled some recent studies along with CDC data to provide this information to you. And if you look it over, it was pretty shocking that 1/3 of all adolescent health maintenance exams or physical exams in a study showed that they got no discussion around sexual health, no questions around being sexually active. And for the 2/3 that did, the discussion lasted an average of 36 seconds. So you can imagine how much information or what type of information is able to be given in 36 seconds and what you can learn from a teen. It's not very much. Additionally, 60% of sexually active females in our targeted age group didn't receive chlamydia screening in the last 12 months, and a quarter of sexually experienced females and a third of males didn't receive any reproductive health services in the last 12 months. So we know that there's issues. There are evidence-based recommendations, national organizations that are recommending comprehensive sexual health screening. So it's not like the recommendations aren't out there. It's just trying to figure out how to put that into practice has been kind of the barrier between what we know and what we're doing. Within the last 2 years, Title X funding has changed some of their requirements, and now organizations must provide screening for adolescents around sexual health, which was probably already happening, some history related to sexual risk, some of those additional risk factors, specifically intimate partner violence, substance use, and depression. So federal requirements are coming along to add in those additional factors when we're talking about sexual histories and sexual health. The CDC released a statement that screening for risky behaviors, provision of interventions, and provision of clinical reproductive health services are essential for adolescents in preventing STIs and unplanned pregnancies. And some of the suggestions for ways to improve sexual health services were to expand the use of technology to improve service delivery and to take a more collaborative public health surveillance approach so that effectiveness of the interventions and clinical services can be monitored. So looking at that statement and those recommendations and trying to put some of that into practice for primary care providers and school-based health centers is kind of the birth of this Act for Change project. And this was a pilot project that really focused on implementing practice change. So if you were going to implement risk screening and behavioral counseling into a busy practice, primary care and school-based health centers, how could that be done in the most efficient and effective way? So that was really kind of the bigger picture for the project. And what I'm going to do is turn it over to Ashley Barrington to share some of the project overview and background of what we were trying to achieve.
Thanks, Jen, and thank you all for joining us today. I'm really pleased to be here speaking with all of you. Jen, do I have control of the screen now?
Yep.
Okay, the little arrows are not popping up on the bottom for me.
You should be able to click your arrow on your keyboard too.
Okay, thank you very much. Thank you.
Sure.
So let me go backwards. I just wanted to get some of those kinks out of the way early on. Thank you all again for joining us today and for listening to us as we talk about this project. The Act for Change project, the name of which probably doesn't make a lot of sense for most of you right now, but which you'll surely understand by the time we're done, is the name that we gave for this CDC-funded project that looked at integrating STD behavioral counseling for adolescents. The purpose of this project and really our design was to take a look at how in health centers we can start with sexual risk-based counseling for adolescents. So in health centers that looks at how it could fit into family medicine or pediatric departments in your traditional health center and also school-based health centers. We wanted to really look at when and how to capture adolescent sexual health risks, sexual histories, and how best to respond with tailored counseling and care. And of course, as I'm sure you all know, you know, how are we able to do this with a population that's as tricky as adolescents are? Those kids who have, you know, big adult level concerns sometimes, but, you know, are living in that gray space where their parents are really involved in their care still. So we were trying to solve that puzzle in this year of this project. So our approach, or really our strategy for this project here at NAC, was to do the following: to engage some key partners, including a health center controlled network, which in this instance is Health Center Network of New York, to integrate the use of some kind of risk assessment, which in this case was the adolescent counseling technology. That's the ACT, in the Act for Change, within the primary care encounter, and to design a behavioral counseling protocol, so to be able to have those tailored, effective conversations with teens. All of this, of course, within the busy primary care setting. So that those partnerships were key. The vision for the Health Center Controlled Network is that their role in working with their member health centers who would be doing the implementation is that they are the ones coaching the teams around implementation, supporting data collection, and all of that. That comes with testing out a new, you know, risk assessment and new counseling strategy. And really to integrate the use of the ACT tool, the risk assessment tool, and a tablet-based data collection tool, again, in the busy, finding a place for that in the busy primary care practice, and also, again, that tailored counseling. So that was really our strategy for solving this puzzle, or beginning to solve this puzzle, I should say. Our aim for this project, really, our vision of products that would result ultimately for this project were for the health centers that were involved in this initiative to come forth with some model workflows that really work for them around engaging adolescents, to refine a quality improvement model that is effective for getting health centers to a place where they can do this kind of risk assessment with their teens and engage in this kind of counseling with their teens. And ultimately, the dream is, of course, to develop a change package for distribution among other health centers and practices that are interested in engaging their adolescent patients around their sexual risk. So, you know, the vision for the model here is that this is something that's scalable, something patient-centered, something that fits into the flow one way or another, and really uses and adjusts existing HIT systems and complements them with other systems like the ACT tool. So just a quick glance here at our organizational structure. As mentioned, the Centers for Disease Control and Prevention provide funding and guidance for this project, which we're very grateful for. We here at NAC are the conveners, and the real key players here are down below, and that's Possibilities for Change, which is the developer of the ACT module, which you'll be hearing from Jennifer again soon, and HTNY, which is a health center controlled network based in New York, but supports health centers in a variety of states, and you'll be hearing from Stephanie soon. And then those 4 health centers that really did, you know, the bulk of the work in trying to figure out how this kind of risk assessment and counseling can work in the primary care setting. And just for context and perspective, what the timeline for this particular part of this project ultimately looked like was a few months at the beginning of the calendar year around site engagement and training, including, you know, training on the new tool, training on motivational interviewing, and of course figuring out, you know, base workflows for this work. A period of about 3 to 4 months of pilot implementation, and then about 1 to 2 months of data collection at the end. I'm now going to turn the presentation over to Stephanie Rose from the Health Center Network of New York. She'll be talking with us about some of the initial implementation strategies.
Thanks so much. Okay, make sure I go back. Okay, so some of the strategies that we were really trying to take a look at was engaging those pilots and seeing if we could incorporate the ACT-SH tool. So it is a separate tool outside of our electronic health record figuring out how can we incorporate that and use it in various methods, whether it's a physical exam, those that were focused on maybe STI screening and birth control, which presented a good opportunity to kind of jump into it. We did also, some of the groups also tried looking at, could we do it during like a sick visit, or, is it reasonable to do during a group visit, or various types of things, and those even that they've added that could be a follow-up visit that was specifically scheduled just to address ACT and to do the ACT-SH when they had some sufficient time to do it. So that was some of the areas that we were taking a look at, or the pilot sites actually. We're doing the yeoman's job of actually taking a look at all that and seeing what worked. So that was definitely a good thing to take a look at. So what we did find is there are many ways to fit ACT-SH into your workflow. Some things work better than others, and it really depends on your practice and just how busy your practice is, what the workflow is. So there's a lot of different variables in it. The sites themselves, and when we took a look at the characteristics for that adolescent population for those particular pilot locations, then we can see kind of some background. They're definitely fit well into what we would expect to see from a federally qualified health center. They have some varying different backgrounds. They're located in different areas, 2 in New Jersey and 2 sites in New York that were pretty close together. So even though they're not that far apart geographically, they do have some different populations that they support on that. And 3 of these sites actually do have a fairly large Hispanic population whose primary language is not English, and all of them do serve a fairly poor population with many that are uninsured or Medicaid patients. The pilot patients themselves, so those patients that did receive ACT-SH, we wanted to see, did they match the characteristics really of, were we capturing the same thing that we would expect to see from a health center perspective? And they are very similar. For the most part, we did have a pretty representative population when we looked at the patients that completed ACT-SH from that were ages 13 to 24. Most of them, again, as you can see, they're pretty much the same. There was a slight difference of patients that were uninsured went down a little bit when we looked at those patients that completed the ACT-SH. We also took a look at the sexual orientation and gender identity information. Now, this information came actually from the ACT-SH tool, because at the time of the pilot, our pilot health centers had not implemented the SOGI requirements that we're starting to capture for UDS reporting purposes. But we do have the information, and we're able to link it up with the pilot information. So being able to have that same being able to link data between ACT-SH and eClinicalWorks, which is our electronic health record used by all 4 of those organizations, really made added some great information about that population. So let's turn it back over to Jen. Yeah, go ahead.
Yep, thank you. So we're going to share a little bit about the 3 health centers that really kind of took on the project and made it happen within their health center. One of them had a lot of other projects and things going on, so ended up having to drop out kind of right at the very beginning. So we had 3 health centers that kind of went through that implementation timeline that Ashley shared. And the first one that I want to talk about is Horizon Health Center. They used both their medical assistant and their healthcare provider in implementing the ACT and the behavioral health counseling. What they did in their morning huddles is the medical assistants reviewed the provider schedules, looked in eClinicalWorks to identify those patients that were on the schedule that they knew were sexually active, using different templates and notations from eClinicalWorks, which Stephanie will share with you a little bit later. The medical assistant, if they didn't know if the teen was sexually active, used a standardized question and asked teens when they came in if they were sexually active. If they were, then they were provided the ACT and part of this clinical project. Their workflow was to have parents wait in the waiting room, and the medical assistant takes the patient back to a separate intake room to complete intake information, to get kind of that height, weight, blood pressure, those kind of things. And at that point is when they put them into the ACT system and had them complete the assessment using the tablet. So there weren't any different changes related to taking that teen out from their parents, because that is a key point of having teens complete an assessment and not having their parents sit right next to them. So that was already their workflow, so that fit pretty well into it. So they set up the patient. If they completed the ACT within that kind of intake time, that was great. If they needed additional time, the tablet was brought with them back to the exam room as they're waiting for the provider to come in. In the Bergen office for Horizon, they had 3 pilot providers, a pediatrician who was the main provider working within this project. Then they also had an OB/GYN and a primary care physician. So they actually had 3 physicians, with one being kind of the point person. The healthcare provider then reviewed the ACT-SH online using their computer and provided motivational interviewing techniques to counsel those teens on the behaviors that were identified. Open Door, Port Chester High School, the school-based health center, they identified sexually active students from a comprehensive risk screening that they were already doing called RAPS. So when teens come into the school-based health center, they complete a RAPS assessment, which asks about a lot of different behaviors that might put them at risk, and identified those teens that were sexually active from that screening tool. And they were scheduled for a separate visit specifically focused on sexual health. They also incorporated the ACT and the behavioral counseling into students that were scheduled for HIV testing and or family planning visits. So that was the way that they incorporated. The medical assistant kind of registered, got the student ready to complete the ACT on the tablet, and the healthcare provider reviewed the ACT online and also incorporated motivational interviewing techniques into their counseling with the patients. They have a much more limited staff in the school-based health centers than in the primary care offices. So basically the medical assistant and the healthcare provider work together. And then at Sioux Fall Health Center in Dover, their providers review their weekly schedules to identify the sexually active patients. So they would review their schedules. We had a pediatrician that was the champion for this project at Sioux Fall, and towards the end of the implementation, she recruited her partner physician to also participate because she thought it was such a great project and a great way to kind of understand patients' sexual health needs and provide services. So at Sioux Fall, they did something a little bit different. They have patient navigators that are at the front desk when patients come in. So upon arrival, when adolescents came in, they were reviewed previously, so there was notation in eClinicalWorks that the ACT Sexual Health module would be part of their visit. They took that patient or that adolescent to complete the ACT on the tablet in an intake area. So they have a separate area kind of in their waiting room that patients would use to complete insurance paperwork or something else that needed to be more private. So they had them complete it in that area, and then they printed out a report from the ACT-SH and handed that to the healthcare provider in order to review it and provide that behavioral health counseling with the teens. Then they actually scanned that printout into eClinicalWorks under patient documents. So they did things a little bit differently. One thing about Sioux Fall is that they felt like this project, having the patient navigators be a part of kind of explaining to the teen what they needed to do with completing the ACT and confidentiality, really helped them feel like part of the health team and really made them feel empowered to kind of implement the project as part of that team with the physician, and they haven't had that opportunity with other projects. So that kind of came out as a win for Zufall on kind of their staff engagement and feeling like they were part of the healthcare that was being provided in a different way than what they normally do. So we incorporated these tools and trainings to help facilitate practice changes. And what we're going to do is talk through each one of these and include some of the results that we gathered as part of implementing these different pieces. And Stephanie's going to start out talking about a CQI worksheet.
Great. Thanks so much. So the electronic quality improvement worksheet, or the eCQI tool, can actually be downloaded from the handout section of this webinar. So if you take a look at the panel probably on the right side, you can download that along with some other items. The worksheet is really a great method to document and understand your current workflow, and it uses the 5 rights framework. So it identifies opportunities for changes before, during, and after the patient comes into the office, as well as many other opportunities that you could still influence the patient and the whole workflow process. So it does give you a good framework, probably more so than some of the other ways that we used to capture it. And it's a very structured tool, and it leads you down the right path from a quality. So as part of that worksheet, the practice could use that information, perform short PDSA cycles to determine what changes are effective, and really take a look at how we can make some changes and how do we implement things, and it's kind of a step-by-step. We did find that it's important to know that that you actually perform the assessment, because it does give all participating staff a chance to really understand how you could integrate the ACT-SH tool into the practice, and kind of gets the buy-in to actually doing the process. So it is a great tool. I highly recommend that you use this if you're interested not only in the ACT project, but any project if you're not doing so already. In addition to the eCQI worksheet, it was pretty important to take a look at at configuring eClinicalWorks, or really any electronic health record, so that the information captured is stored in a standard and structured way that allows your organization to have valid data. Oftentimes what we found is that questions about a patient's sexual activity is buried in the textual notes found throughout the chart. So you might find it in various progress notes, or it's in multiple locations. It's really difficult to find information about, is the patient sexually active or not, or at what point were they sexually active. So we might see some questions of patient sexually active with a yes, no, but no date. Was that recently, or was that 10 years ago? So it's really difficult from a reporting perspective to have usable data. Even if it's buried in a progress note and people have to go searching for it, the odds of anybody being able to use the data is pretty minimal, not only from a provider perspective, but certainly from a reporting perspective. It becomes almost impossible to do anything with it. So it's important that you realize and take a look at what your particular electronic health record has set up for capturing sexual history. In eClinicalWorks, they do have a sexual history smart form where the data is mapped, and that's where they use information for clinical decision support alerts and various other things. It has a really specific question about what time period that you're referencing about being sexually active. And we also know what date that sexual history was completed. So it does give us an idea of, have they been sexually active in the past year? Some practices also added information, as Jennifer had mentioned, about scheduling, so that was helpful to really alert the clinical staff that ACT tool was going to be part of the visit. So that I really thought was a great idea. We did recommend creating structured data in eClinicalWorks also to document if the patient completed the ACT-SH tool, just so it's easier from a reporting perspective. It's much more visible. So if you're working on a patient chart, or you're working with the patient, you know that they've completed the ACT-SH and potentially that they did it at a certain time period. So maybe if they come back in you know you don't have to start over from scratch, or maybe that you need to follow up on that. Some of the recommendations that we had came up with is really creating a template. So instead of trying to remember all those things that we're supposed to document, such as specific CPT codes that we're supposed to check off that we completed ACT-SH, creating a template that they could just merge in with a progress note would make that a lot faster, and that lets our providers focus on doing their work in counseling and a lot less on just the mini clicks that that they really don't need to be doing just for documentation's sake. So really just developing a process is helpful, and then, you know, from a future perspective, certainly taking a look at better ways of doing this and make it a lot less manual and less click is on the radar for things that we would like to do. I think one of the more interesting things that came out of the project of being able to capture the data is looking at what happened on the sexual activity screening. So this was strictly focused on the eClinical Work Sexual History Form. So when we say they were screened for sexual activity, that's where I was looking for it. By really focusing on this project, we did see an increase in the number of providers and staff that were completing that. So that was a big win. Now, we've been focused on trying to capture that information for a while, as we've been trying to reinforce STI testing. So I was so glad to see that we were able to gain even more momentum. Now, interestingly, if we look at those patients that were sexually active, not only just because they said they were sexually active on the SMART form, but also those that we call presumptive. So maybe you had an STI test, or you are taking birth control, things that would give you the idea that there's probably a reason that that was happening. And so we've expanded it just because we know not everybody was filling out the sexual history form. And even that, we do find that many more patients were being identified as sexually active. So more screening would actually lead to much more information being out there. We did see improvement in STI assessment, so really, or an increase, not really an improvement, but an increased number of STIs that were assessed, so hopefully capturing a few more. And that screening was, rates went up, so that was a pretty remarkable improvement. Sometimes it's just a matter of capturing it, and that also, I think, combined with really that focus that ACT-SH brought to it, made a big difference. So I think it really was a great process, and it definitely showed some improvement.
So we're going to talk a little bit about the tools that were used, the ACT-SH, we referenced it quite a bit, and also the motivational interviewing training. So there's information in the handouts that are part of that panel for GoToWebinar that you can download on the ACT-SH and also on the motivational interviewing. So the ACT-SH acts like a virtual health educator. So it provides interactive and evidence-based risk behavior assessment and the counseling that supports safer sex action plans. So safer behaviors around their sexual activity, like consistent use of condoms and or another form of birth control, like a hormonal birth control method. So the technology, it takes about 10 minutes for you to complete the assessment and receive that individualized health education. Then they have the in-person piece where they're meeting with a provider, and in our case, it was either a physician or a nurse practitioner, to have that follow-up discussion for them to really provide that behavioral counseling around those identified risks, as well as the safer sex action plan that would have been developed from the ACT Sexual Health. And then as part of the intervention, there's a text messaging reminders for teens. So they can opt in to receive text message reminders around their motivations for being safer, around their action plan that get sent through the system. They're standardized messages over a 3-month time period. So it's really 3 different components that make up the ACT, the technology, that in-person interaction, and then the follow-up. This is what the youth see when they complete the assessment. They see one question on a page. They're able to listen to all the text on the page if literacy is an issue for them. They receive very brief health messages related to how they responded to questions. The system uses questions to put them in a stage of change, whether they're pre-contemplation all the way to action. And the questions and health information that they receive is really based on their stage of change. So it's very tailored to that specific teen, so they don't feel like they're just getting messages that are canned that anybody would see. When they complete the assessment, the system will open up a safer sex action plan for them. If they got to a point where they created a goal, like you see here, you said you're going to use condoms with every sexual encounter. That was something that in this demo we chose as a behavior that we wanted to try to achieve. In addition to having that goal written out, the key pieces to really achieving that goal is remembering kind of why you're doing it. What's your motivation around that? Also keeping on track, what are some of the steps that that teen felt like they needed to do or achieve before they could achieve that goal? And also, what did they say were some of their challenges? What are things that they thought might get in the way? And the system has created some brief self-education around overcoming those challenges as well. So there's lots of options as they go through and complete the assessment for choosing their motivation, what would keep them on track in their challenges, and they also can type in their own if they don't see the option as a selection. On the clinician side, what the providers see is that safer sex action plan, just like the teen received when they completed the assessment, discussion summary messages, so some of the other health education that that teen received as they went through the system, so that they could either continue a discussion or be able to respond if the teen asked a question about it. And also, if you see the first panel, they will see a comprehensive sexual health history. So the system will document for a provider that comprehensive sexual health history. It's based on student responses to the assessment as they're walking through it. And it's broken into categories of risk and behaviors. So kind of in the very beginning, how I talked about the behaviors that the CDC identifies as putting teens at higher risk for STI and unplanned pregnancy, and also those additional factors like depression, like academic success. So all of those are assessed within the system, along with some of the history around where they're most likely to have sex and meet their partners and their history of testing. So it really prompts a provider to test if they're at risk or they haven't been tested in a while or ever. Some of the data that we got, and I don't think we've said yet, but there were 100 youth that completed the assessment in that 3 to 4 month time period between those 3 sites. And what we did was kind of looked at the behaviors that they were identifying. And if you think about what I shared at the very beginning, the YRBS data, you'll see that for many of these behaviors, this population is at higher risk than what's being reported across the U.S. in the YRBS. So you can see their report of having sex in the last 3 months, using a condom, having 4 or more partners, and then using substances. We also took a look at screening based on their reported levels of screening, so that may be different. They may not have known that they were screened or remember, so that could affect some of the numbers. But less than half of this population reported receiving STI screenings prior to this visit, while 1 in 5 reported a history of chlamydia. So you can see kind of how that fell out. And one of the health centers, their experience is that they were identifying many more positive chlamydias than they had in the past when they were screening their population outside of this project. So that was a great win for providing the health care that was needed for those teens with positive tests. And then some of the other information that we thought was interesting is that within the Act, teens are asked if they want to receive the health messages, so it's not an automatic. And according to kind of theories around communicating with teens and providing education to them, if you agree or say that, yes, we can talk about this, or I want to have more information, you're more open to hearing it and reading it. So that's why we put that question in there, so we don't just give it to everyone. 86% opted in to receive the health education that was provided within the ACT system. 54%, or just over half, opted in to receiving text message follow-up after their healthcare visit. And 88% created a safer sex action plan. So an action plan of using condoms and or another form of birth control with every sexual encounter. So that was a great starting point for that face-to-face visit with the provider, that they could kind of talk through those plans and what it would take for them to be able to achieve it. Some of the teen experience that was reported, they liked interacting with technology or with the ACT sexual health. They felt like they learned new information and thought it was comprehensive, that everything that they were experiencing around sexual behaviors or dating and things like that, they felt like was included within the assessment, and that they could be more honest when using a tablet to disclose and still wanted to have that face-to-face interaction. Some of the provider results, so we had 6 physicians and nurse practitioners that were really key in being the provider that was implementing this project. Their feedback, you can see here, that all of them felt like the ACT helped them identify risk behaviors and direct that risk behavior discussion, and 2/3 of them felt like it really helped develop rapport and improve communication with their adolescent patients. And you can see some of the most common topics that were discussed within the visits. And I think sexting was new to many of the providers as a topic of discussion. We also had them self-rate their ability to gather comprehensive sexual health histories and create those safer sex action plans with their adolescent patients. And you can see the blue was their self-rating before participating in the project, and the orange is their rating after. So they really felt like they improved in gathering those sexual health histories and creating those plans. And then the second chart on your right is their self-rating of their effectiveness, or their feelings of effectiveness in counseling teens on reducing their risky sexual behaviors. So before the project, in blue, how effective they were feeling, and in orange, after participating in the project. So we were really happy with some of these initial results of the pilot as well, because providers need to feel capable and effective in the care that they're providing in order for them to kind of follow through and ask about sexual health and discuss, have that counseling visit. Some of the other feedback that we got that was either intended or unintended benefits, they felt like using a risk screening tool and using technology really helped open up the discussion for goal setting. It gave patients the message that it's okay to talk about sexual matters and sexual health, and that it really ensured that the needs of sexually active youth were being met, that nobody was being kind of bypassed or that they were being missed, basically. And some of the adolescent responses, that providers felt like adolescents, that it helped them understand their own sexual risk behaviors and potential outcomes of those. It gave them an opening, again, to discuss some of their behaviors and experiences, and that adolescents felt very positive about using the tool. So in addition to having a tool, it's really important that providers feel confident and skilled in having that discussion around sexual behaviors and safer choices or safer options. So we provided an adolescent-focused motivational interviewing. We went out to New York and New Jersey and provided a workshop that really helps professionals take motivational interviewing knowledge and experience and put that into practice. So some professionals came in with kind of knowledge and use of motivational interviewing, and others were starting kind of from the beginning. So it was great to really help them improve identifying behaviors, communicating with their adolescent patients, and really seeing that difference in adolescents, talking with them and helping them move towards positive changes. So the workshop that we offered had an online component. This was very interactive, kind of learning modules that were completed prior to the in-person session. And there were 8 CE or CME credits that providers received for that, completing those modules, and then the on-site workshop. So it really translated that knowledge into effective practice with adolescents. We had 42 staff that were trained in motivational interviewing, so it wasn't just the providers that were going to be counseling teens on their responses to the ACT, but really it's about practice change. So the patient navigators and the medical assistants and the nurses and other staff that would also be interacting with adolescents were a part of these trainings, so that there's kind of a culture of communication with adolescents that flows through the process of adolescents during intake as well as when meeting with the healthcare providers. This is just an example of some of the activities. You can see the online module is very interactive. There's videos that go along with it and activities that help kind of incorporate not just the knowledge, but how you might use that in practice. Some of the results specific to the motivational interviewing. So after we completed the training, you can see here we asked a self-rating of skill in using motivational interviewing before the training and then after, using those communication strategies. And you can see in blue that we had a variety of skill in the providers before and then after, where people felt like their skill level was. And then also confidence. So you can see confidence ratings before the training in blue and after in orange. So we were very happy with kind of helping providers feel more skilled and be more skilled in using behavioral counseling that's shown to be effective when talking with teens about risky behaviors. Some of the written provider results kind of grouped into categories. So they felt like the motivational interviewing strategies were great not just for sexual health, but really on all kinds of behaviors that you would be talking to patients about. So nutrition, substance use, it really helped to have that training and background to plan ahead. When you review the ACT, you can see kind of what behaviors that you might be talking about with your teen patients. So some of the providers really planned ahead what to say, how to approach a youth, how to start a conversation, thinking about the different techniques and strategies in motivational interviewing, that it really changed how they were talking to teens. Instead of lecturing, which we know doesn't work very well, they were really asking, and there's a quote here, what do you think you could do? Which is really important to make teens feel in control and respected for what they think they can do, what their options would be in their own minds, instead of just telling them what you think they should do. And that their discussions were really around goal setting versus just talking in general about being safer. So what is a goal that that teen could actually work on? What are the steps they needed? And what would help them achieve that goal? So I'm going to let Ashley kind of summarize some of the things we were talking about and add in anything else that we may have missed as we're kind of wrapping up some of the results that we got.
Thanks, Jen. So this slide here, workflow planning and considerations, is really just a bulleted list of what Jen and Stephanie just spent a fair amount of time talking to you about. You know, this pilot project was relatively brief, with really the startup and the coaching and everything happening in a fairly short window. But we did learn a lot. We learned a lot about the value of pre-planning for both the implementation of these new tools and processes and ways of engaging adolescents, and also pre-planning and preparation for the actual adolescent visits. So it's kind of two-pronged. The visit types, Stephanie mentioned the health centers that participated in the pilot tested a lot of different types. Specific visits using these tools, trying to weave into well visits, trying to weave into a variety of visits, and even considering, special, tacking on to HIV and STI screening visits, all kinds of varieties. There's many ways that these tools and workflows could be used. So that was a really interesting lesson learned from this project. One key item that Stephanie pulled out is that initial piece of identifying your sexually active teens and actually knowing who they are, how critical it is to know that information so that you can intervene appropriately. And that was a really, perhaps in retrospect, obvious, but I mean, it is really important, and you need to have your supportive HIT systems to help you with that, to make those clinical decisions as well. Bleeding into their documentation and integrated HIT, any of you who work within EHR know there's a long way to go to having it really support you in the ways you need to be supported, and engaging your patients and working with them and giving them exactly what they need. Sometimes they're barriers, oftentimes they're barriers, but we learned a lot in this pilot, as with a variety of other quality improvement initiatives that I'm sure you've all been involved in too, how critical it is to be able to have a system that allows you to enter the information into your EHR and be able to use it, and also to be able to pull it back out again. And also, when you're talking about, as in this instance, where you have two separate systems, both the ACT tool, which is a separate, something you access separately from the EHR, thinking about how to straddle that line of, leaving the ACT tool as something that's useful, and perhaps leaving sensitive information out of the EHR, but also having information in the EHR that can facilitate the flow of the visit and future visits and information for the patient. In that same vein, privacy and confidentiality. I'm not sure, I may have neglected to mention this, I'm not sure if Stephanie or Jen did. Our initial thought of this project was that it was really important to teens that this kind of sensitive, sexual information was not in the record. And I think as the health centers experimented over the pilot period, they learned that sometimes wasn't as big of an issue for the kids. The things that were really important in terms of privacy and confidentiality were the kids' ability to use the tablets to input their information in a private setting. So if their parents aren't looking over their shoulder, nobody else is looking over their shoulder. That was really key, just to get the information out there. That was really, really important. And then the last piece, as I think when we talked about the different models at the health centers, that team approach. It's not just the provider, it can't possibly be. So what's the role of the people at the front desk? What's the role of your medical assistants and patient navigators? The different health centers, the different workflows all used team members differently, but it was nice to see that there are a variety of options.
Great, thank you. So I'm just going to review some other kind of ahas that we learned as we went through this pilot phase and working closely with the three basically health centers. Really having the youth give input on their prevention or their care plan and being accountable showed very positive results. Them feeling more in control of their care, that they had options and choices really mattered to them. I think a lot of times we assume that teens just come in and they don't really want to participate in their health care, but really when you give them the opportunity, it made a huge difference in kind of the discussion that the provider had and the process for creating that safer sex behavior plan. The other piece that came up in the school with the school-based health center team, who are very experienced with adolescent care, that's the population that they see day in and day out, realized after participating in the project that they weren't fully assessing sexual health risk, because it is very comprehensive, and behaviors that might impact sexual decision-making, and that motivational interviewing was an approach that they weren't necessarily using when they were counseling teens on those behaviors. So they feel like their care, the sexual health care they're providing, has been greatly impacted and improved in a setting where preventive care is typically already at a high quality. In general, the providers felt like this project really helped change the way they talk with adolescents about sex and other behaviors, that it was much more comprehensive. They learned a lot more about their patients, and what was once a top-down directive is now from the adolescent up and more client-driven. So I was really excited to see that comment and provide that as one of the ahas and practice changes that came out of this project. And I think Ashley is going to kind of wrap up the webinar for us. And if you have questions, then please type them in the question box, because we'll spend a few minutes after kind of answering those questions.
Yeah, so this lessons learned is very similar to the workflow pieces. We learned a lot from this project, even though it was brief, and even though by no means do we have full functioning systems in place in any of these pilot sites. System integration is critical. Those kind of system pieces around planning for workflow change, and then the team's opinions of these activities and how it makes them feel as part of their care. Do they feel like their information is safe and protected? Do they feel that they can respond to the questions being asked of them so that their providers can help them make smart choices? We feel like these tools that were implemented and tested and piloted in this project really were useful, and that there's still a lot to learn. Future opportunities, we hope there's many paths that we can continue to pursue. Again, as we mentioned, implementing the use of assessment and counseling as really part of routine care, figuring out workflows that can work consistently for sexually active patients, so that providers can be sure that they're providing the advice and counseling that the patients need. Figuring out how to work around those tricky areas of parents. There were definitely plenty of issues raised from the sites and by parents about this tool and these conversations. That's always kind of there, and I don't know if anybody's found the silver bullet for that issue yet, but that remains. Figuring out reimbursement strategies and coding strategies, and ultimately getting a change package that's useful for those of you in the field to figure out how to do assessment and counseling in your own sites. These are some of the visions for the future.
So I think, yes, those are kind of our thoughts and information around the project. We tried to keep it within the hour that this webinar was scheduled for. We do have a few questions. If anyone has more, please feel free to kind of type them into the box. Also, as you can see here, all of our email addresses are included. So if you had questions specifically for Ashley at NAC, for Stephanie at the Health Center Controlled Network, or for myself, please feel free to email and reach out. That would be fine. I think two of the questions are related to getting a copy of the PowerPoint slides. And yes, we can send those out. I'll send those out to everyone that's participating on the webinar so that you have a copy that you can refer back to if you need to do that or you want to do that. And we have another question around implementing ACT-SH. How can we implement ACT sexual health in our own clinics? I'd love to roll it out here. So you can see my email address here. If you reach out to me directly, we can talk more about how that can be implemented within your organization. So with no other questions, thank you again for participating in this webinar. We hope that you learned some information and had some things that you could take back to your organization. And if you do have other questions, please reach out to us. Thank you. Have a good afternoon.